Good morning, everyone. We're going to go ahead and get started on time. And for those who wander in late, it's their loss. They've missed out on all the important things we've already said. Welcome to the panel this morning, addressing critical challenges in healthcare technology innovation, a very small topic with narrow focus for us. My name is Max Lawrence. I'm the Senior Vice President for Surgery, Orthopedics, and Neurosciences at Yale New Haven Health. I am a faculty member in the School of Medicine in the Department of Neurosurgery. And
can you bring the mic a little closer?
Is that better?
Yes.
Okay. And the faculty co-director of CBIT, our Center for Biomedical Innovation and Technology at the university. I'm really pleased to be here with this distinguished panel. I'm going to function as moderator today, posing questions. I would like to have an opportunity for the audience to ask questions as well. So if there are things that are on your minds, and depending on where the conversation takes us, we'd be happy to hear your comments and participate in this in a discussion. I think I'll start just by asking each of our panelists to introduce themselves and just give a brief view into their journey and to how they've landed in the particular positions that they're in today. So, Tom, we'll start with you.
Hi, everybody. I'm Tom Tesser. I'm the COO at a company named Hyperfine, which is just down the street here in Guilford, Connecticut. It's a portable MRI company, and we're kind of focusing on accessible, affordable MRI. So we can talk more about that kind of as the session goes on. And previously at Google Life Sciences, so helped to start up Google Life Sciences and a number of companies in surgical robotics and implantables, laser cataract surgery, but largely background in connected medical devices. That's kind of where I focused my career. So great to be here.
Hey, folks. My name is Joe Petro. Today, I'm Corporate Vice President at Microsoft for Health and Life Sciences. It's about a $13 billion business. Been doing that for about 3 years. And about 3 years ago, I was running research and development. I was a CTO at Nuance Communications. So we got acquired by Microsoft back then. It was a $20 billion acquisition. So it was a pretty big exit, and it kind of was the starting point for what Health and Life Sciences at Microsoft is today. And prior to that, I was with Eclipsys, ran an electronic medical record vendor. I still have post-traumatic stress syndrome from that. I don't recommend anybody go into that field at all. And then prior to that, I was outside of the healthcare space. So welcome.
Hi, my name's Curdy Levy. I'm the current managing director of Techstars Boston. Techstars is an accelerator with about 50 accelerators worldwide in general topic areas, but also healthcare specific, actually many verticals, food, ag, space, you name it. I've been at Techstars since 2019. I ran Techstars Iowa for 3 times, and then I've been in Boston for 3 programs. My background in healthcare, I've sat on the board of a hospital for 9 years, and my personal interest, I've invested in 10, 12 companies in the healthcare space. So I'm sort of healthcare light, but I just love this space. And we literally see thousands of applications every year. So it's really interesting to see what the world is inventing in the space.
Hi. Can you all hear me? Sorry, I have a little bit of an ear infection. So, Ian Chang, I'm one of the partners at Flare Capital Partners. We're a Boston-based VC firm, early stage but full life cycle, roughly about almost $1 billion of AUM. We tend to focus on investing in companies can go from pre-seed all the way to Series B, and we'll continue to do our pro rata throughout the life cycle of the company. One thing maybe I'll call out Flare, and of course there are a lot of investors out there, but since the inception of Flare about 10 years ago, we take a deliberate approach and really try to build an ecosystem to partner with incumbents in the industry, knowing just how difficult healthcare is. So roughly about 30% of our capital comes from approximately 20 strategics. So some of the largest health plans like Humana, Centene, Aetna, some of the largest health systems, Cleveland Clinic, UPMC, Intermountain. So while we're a financial investor, but we tend to try to help portfolio company, but also doing diligence, introducing them to the right key stakeholders. So over the past 10 years, about like our portfolio company sold roughly about almost $700 million of revenue to our strategic LPs. So together we try to innovate healthcare to the way we all wanted it to be. My background, very briefly, before I joined Flair 5 years ago, I was on the operating side for a good chunk of the past decade leading up to it. I also founded a company back in the very early days before digital health or mobile health was a term. Company evolved a few times. It was a mobile diagnostics company. We use OCR to read urine test strips, and then ultimately Becton Dickinson bought it. I also spent some time as a large company entrepreneur, so joined Cigna to help launch the Care Allies business, which was a value-based care enablement platform, and Cigna's bundling it to sell to HCSC with the Medicare Advantage business for about $3.7 billion. And I led the product organization back then, so I saw many of the challenges of adopting novel technologies. So happy to be here.
Well, why don't you hold on to that mic for just a moment, Ian? We'll come back down this way with the next question. So thank you all for those introductions. And I think that you can see that the panel we've assembled here really spans the spectrum of innovation. And, you can define innovation in many different ways and pretty broadly. But we have investor, accelerator. We have Joe, who's part of a large company in the form of Microsoft. We have Tom, who's part of a smaller company. So we really have a spectrum of representation here. So maybe we just start high level. What you see as what's required to make for a successful innovation. What makes innovators succeed? Where do you see them trip up and fail? And maybe we can also touch on this idea of what's real versus what's not. What I think a term that we used in our prep session was what's like a hallucination, and how does that confound the problem that you see in new innovation in healthcare?
Should I start?
Yeah, why don't we start with you, and then we'll march back down. We'll go in the reverse direction.
Well, I'll keep it brief, and especially the hallucination. Maybe Joe can best speak to it. But I'll highlight, especially with his insights into OpenAI and various work Microsoft is doing. But I'll talk maybe a little bit about what sets apart successful innovation versus not, especially now as an investor, we survey our strategic LPs, talk to them on a weekly basis, many of them who are buyers of the assets company, as well as being on the operating side. I think many folks actually talked about it throughout the past couple of days. It's really, when you look at healthcare, everything's, I almost never run into a problem that's not a problem, right? But it's really about the prioritization. So first, as a former buyer of innovations, right, when I was running the product organization, and also Cigna, fairly large companies that has a lot of unmet needs. At the enterprise level, I still remember 1 year, Cigna went through a process of soliciting innovations, from different businesses, what we should invest in innovation. There are 4,000 plus unmet needs, right? And ultimately, there's only enough budget for something like 25 of them. So if you're number 26, it's still a major problem, but you just didn't make the cut, right? So I think to be able to drive innovation in the healthcare system, you have to not only find a problem, but truly an acute problem that people need to solve almost as of yesterday. And one last thing I will add, and I'm sure a lot of my panelists will have far more insights than I do. I think one of the key challenges of driving innovation is as a former entrepreneur, we always think about what's the best technological solution. However, healthcare oftentimes is really a people and process problem, right? So even with the best technology, if you don't address the people and process part, you'll never get the adoption, right? And this is what we're seeing in a lot of the challenges of driving true innovations, that people don't think critically about how to actually bring innovation from just an idea to true implementation, getting value.
Yeah, cool. Just one thing I'll add to that, on the priority list, one provider told me if a specific problem can be solved with near 100% accuracy with a text, we'll adopt it. Very specific. Like, we'll take it on. But that's what they're going against. I'll speak from the founder perspective on innovation. And so when we're talking to founders, we're really looking for founder market fit. So they understand the market really, really well, or they understand the problem really, really well. They've experienced it themselves, or, they have someone in their family or whatnot. But what I've seen really, really work are those founders who literally talk to the people they are going to be selling to all the time. And they're maneuvering, and they've got the technical capability to take the product to the next level or in a different direction at any given time. And those founders end up being successful. During the process of recruiting, we recruit for about 4 months. And it's actually a little longer because we'll take some people after the app's closed. But we during that recruiting time, I have watched ideas and founders and businesses get surpassed by someone else. So here's an absolutely mind-blowing idea, and this founder is really attached to it. And then 2 months later, I meet someone who's doing that only 10 times better. So it's a really interesting time, the speed at which innovation is taking place.
Yeah, I think so. I'll focus on two sides of it. One is the creation of value, I think, that drives innovation, and then the second part is the hallucination and the mimicking, which is very prevalent today, I think, because of the large language models. But I think part of the problem is focusing on technology versus the value that it creates. Right. So I think you really need to understand, if you're calling yourself an innovator, it'd be better if someone else called you an innovator, by the way. But if you're calling yourself an innovator, you have to really truly understand the value you're creating and how much somebody is willing to pay for that and why they're going to pay for it from you. And that's just old school, right? That's how businesses work from the very beginning of time. And just because we have AI today, it hasn't changed that. I think people got distracted with the large language models chasing, this big shiny bulb, because there was a lot of pressure from boards of directors, from boards of trustees, from clients. Like, what are you doing with generative AI, right? So there's massive pressure. So everyone's running around looking for, a hammer to hit that nail with. And I think that's the wrong way to look at it. And I think the sanity is starting to come back. You need to know your value proposition. You need to know why someone's going to actually pay for it. And if you're selling this into healthcare, you need to understand it's a very, very crowded space. Nobody has any patience or time for yet another application that sits on the desktop. There's already 500 applications on a desktop at a typical hospital. So you have to figure out how to integrate with the workflow, meet users where they are, et cetera, and have an idea that only you can actually crack and make it defendable. Okay, and the defendability of it, this gets into the hallucination and the mimicry. The problem with OpenAI, in a general sense, or large language models or GPT, call them what you will, is you can spin up a proof of concept really, really quickly. All right. And if there's one thing you take out of here, just remember this: no one cares about your prompt. Nobody cares about how special your prompt is. And in fact, in a few years, there's going to be no craftsmanship to the prompt at all. Whoever's focusing on prompt engineering, that's all going to go away. You're basically going to be able to talk to the model, and the model's going to figure out what the hell the prompt should actually be. So if that's your only differentiation, go back to work. And I'm dead serious, because that's not defendable. Anybody can build a prompt. An English major can build a prompt. No offense to English majors. I brought one with me, actually. But seriously, that's the mimicry and the hallucination problem, is that it's just too easy to show something nowadays that looks like it's going to work in production, but it's just a prompt. and that's not enough anymore. There has to be more mystique and novelty to what you're actually doing.
Joe, maybe we could just stay on that for just one more minute. Defining value add in healthcare has been notoriously difficult.
Yeah.
If you think about, and a lot of it comes from the fact that we have a really hard time quantifying outcomes. But when you're thinking about innovating in a space where it hasn't been done at all before, how do you focus on that value? How do you quantify the innovation and identify something real versus what ends up being just a small improvement on an already existing space?
Yeah, I think it's tricky because you get into this, the VCs in the room really know this part of the problem, but you get into like anecdotal value versus measurable deterministic value. Like for us, what we say is we relieve physician burden, right? Because as you all know, all the metrics on physicians, clinicians, and nurses are going in the wrong direction. Depression rates, job abandonment rates, suicide rates, divorce rates, job satisfaction rates. So we want to attack physician burden by making it easier for a physician to do their job. So we provide speech technology, natural language understanding, large language models, et cetera, to do that. How do you convert that notion that quote unquote we're going to relieve burden into something that's actually measurable? You have to figure out what the measurements are. You either invent them yourself or you go to things like, for this thing we've got that basically is a room that listens and it converts it to clinical documentation. It's called DAX. For that, you look at HEDIS scores, for example. You look at, you survey the physicians and you ask them questions about, do you feel better using this product versus not? And you have to be ready for them to say the product sucks. You have to be ready for that, right? But that's good feedback because that'll actually help you navigate. And so I think you have to figure out a way to convert the value proposition into something that's measurable. Then you go out there, put the product in the field, you start to measure it, and then you come back with a product that has a price tag on it, and then validation underneath it in terms of the value. But it's not easy, and I think I've been in VCs before, and I've tried to steal money from VCs for a long time, for a number of years. And this whole thing about anecdotal value versus measurable value is very, very key to it, because I think sometimes as an innovator and as an entrepreneur, you get stuck in the anecdotal proposition and not the measurable one.
So just to build on that, I mean, I think we don't talk about the data enough, right? So if you talk about, spend the time, one of our biggest challenges, right, is cybersecurity, build the plumbing, right? Spend the time doing that. What's the heterogeneity of your data set? These are kind of the questions to ask for things that are, is it actually real or is it differentiated, right? Is it just the sizzle or is there something behind it? And we just don't spend enough time talking about that. And I think, later on we'll probably get into this, but in healthcare, there's been kind of a standard problem of bias in data sets from clinical studies being way too narrow. And that's the same problem in building AI models and building models in general. It's the same. It's not a new problem. The thing that AI will do is it will enable us to talk more about it, and it'll raise the issue, right? And it'll allow us to force the questions. What did you build your technology on? What's the basis? What's the foundation? Is it 50? Is it 50 data sets? Is it 100,000? Is it 2 million, et cetera? And then how did you look at edge cases, variability, heterogeneity, and all of those things? And those are really easy questions to ask. And then you can kind of quickly jump to operationalizing that in a small company. If you haven't allocated enough runway, for compute costs, right? This is like a massive issue for small companies right now. So I'll talk a small company angle. If your compute costs are $1 million per quarter, right, and you have $5 million of runway, you're not going to make it. And that's a really easy question to ask a small company, right? How are you doing that? How are you thinking about that? Because adoption in healthcare takes a long time, and you have to be patient. Kind of getting to the innovation point, right? So first, it's for me, it's patience. Right, so allow for enough time. Right, it's very difficult to predict that inflection and when market adoption will actually happen. So many factors. Look at what happened with COVID. A lot of companies took off. Soon after COVID, they fell off. Right, it's very difficult to predict that. So you have to do the things that are in your control. Inherent to innovation is not an invention, and so inherent to it. It has execution, focus, and operations. And I always go to that. I'm COO. That's kind of what I like to talk about, right? And within operations, it's build the team culture. I like drink all the Kool-Aid about the 5 dysfunctions of a team. And this is like that's the build teams that can communicate, and they'll get you results. Build teams that can have conflict, and they'll get you results. I think another kind of reference is this HBR article, and it basically talks about building cultures of innovations revolve around key kind of areas. And if you look at kind of trends among companies that are innovative, key areas are things like psychologically safe but brutally honest, right? Cultures that are like that, experimental but disciplined. That's another massive one, right? Allow experimentation, but be focused on when you make decisions. Tolerant of failure, but not incompetence, right? These are kind of rigid things in culture. The thing about focus. So you have a team, right? So let's focus the team on clinical outcomes and clinical evidence. So every engineer on my team, the thing is if you don't know our use cases, even if you're an embedded software engineer, if you don't know what use case we're pursuing, you don't need to be here, right? It's build that culture, right? Before you buy the ping pong table and the kombucha, figure out your patient value, right? And build a culture around that. It's really easy to say, but it's actually on the day to day. It's a very rigid thing, right? And I get very annoying about that, right? Which is don't talk about that. Don't talk about visual design yet. We don't have a use case for that yet. So what is the use case? Ask that. And kind of the third part is kind of building an ecosystem of innovation. One of the things we did, the early days of Google Life Sciences, one of the things that we did well was this idea of joint ventures. And the reason why we built joint ventures is, as Google, we said, hey, we don't have there are individuals with healthcare knowledge, but we don't have kind of the institutional background as Google to build medical technology and medical devices. J&J does, GSK does, right? Dexcom does. So let's talk to them and let's build companies. So now you have a company that had market awareness and that had kind of the design inputs, a company that has the development prowess, and then you build a joint venture that is just obsessed with getting a product to market. Because big companies a lot of times aren't, right? And they get distracted. So one startup focused on that, do that. So find ways to build that ecosystem, whether it's partnerships, right, or otherwise, that'll support innovation. I'd say those are kind of the big areas.
Thank you all for those comments. So Tom, you brought up the concept of bias and bias in the development, in product development in general. I wonder if maybe each of you, and we don't have to go in any particular order, anyone who wants to jump in, might discuss a little bit about how you think about bias in generative AI and potential implications. Where do you see it helping to mitigate and improve equity? Where do you see it exacerbating the problem? And how does it influence how you either invest in or approach generative AI?
I could say a couple of things, but I think as operators, as developers, strategists, whatever, we can get really high on oh yeah, this is awesome, this is really cool. If you ask a clinician and they look at a result, this is right. They'll look at the result and say, "What? No. What are you talking about? This is not accurate." I think for me, it's that early adopter innovator before you get to those are your best friends, right? In that part of the adoption curve, because there's never a more engaged group of people than clinicians interested in technology, especially as you build. In my case, medical devices. That group will just spend as much time. They are just so engaged. And they'll figure out, right? Your results. They'll look at your results, say, "What this isn't a real clinical outcome." And radiology is a great example of that. So right now, in medical devices, there's probably about 900. There's about 900 FDA authorized AI enabled devices right now. It's about 900. 75% are in radiology, right? So it's furthest along. Mainly because it matches kind of some of the capabilities of AI to date, right? Really focused on imaging, really focused on video, etc. And the way that technology has been adopted, become essentially standard, is this idea of radiologists really geeked out about it, right? And they tested it, and they pressure tested it, and they over pressure tested it. So it's those people that they have to work with.
Yes, I think how first defining what bias is today from an AI point of view. I'll tell you the way
Can
I
you hold the mic just?
yeah, I'll tell you the way I think about it, just so because I go to like kind of simple mental models as much as I possibly can. So if you look at any data corpus available worldwide, no matter what it is, there's bias in it, and you have to kind of look at where the bias is actually coming from. So, for example, if I went to a bunch of surgical centers and I were to train my AI based on the data that came from surgical centers, no offense, Max, but they say surgeons cut. It's like you go in for the flu and you're under the
You'll get a hip replacement.
Yes, exactly. You're getting a hip replacement. So if you were to train something that was a diagnostic assistant on that data, it would be biased towards the way surgical centers. So you have to kind of add more into that corpus so that you get a much more kind of normalized average view. But it goes further than that. Not only is it a surgical center, but maybe it's a surgical center in middle America where there's a lot of white people, farmers, or it's in Chicago and it's a much more mixed population, or it's someplace in Asia. The problem is that everybody's talking a really good game about the measurement of bias. But the problem is you have to define it first because it's super complicated. And then you have to figure out a way to be able to measure it. And your data actually needs to be tagged in a way that you can actually measure it. Then you can actually say something about how your AI performs on it. All right. So it's super, super complicated. One of the things I've advised internally at Microsoft is that when we're creating these kind of super compelling kind of AI principles and values, like if you look at our AI principles and values on the Microsoft website, it's stuff like fairness, inclusion, privacy and security, equity, transparency, accountability, all these things. That's great. And that's great for marketing. The problem is you need to be able to measure all that stuff. And so what's happening right now, I think, is we're at the very, very beginning stages of putting tools in place so that people can actually measure it. And then you got to figure out what you're actually going to do with the measurement itself. And one of the ethics questions that have come up, I talked to a super, super smart chief medical information officer at Microsoft. And I pretty much failed ethics when I was in college, so it was good advice that he actually gave me. But I basically said to him, what happens if I create an AI model that happens to be trained on readily available data, and there's no other data, and it happens to be able to diagnose something very, very specific, and I'll say this because I am this, a middle-aged white man. That's all it does a good job on, middle-aged white men. If we were to publish that right now, the media would be lining up outside that this is the most unfair thing, and this is exactly what's wrong with AI. But the problem is it's targeted at a very kind of limited cohort. Is that okay to do today? It's a very much a kind of an ethics question. Like, how do we get between where we're at today and something that's much more kind of applicable to the general set of demographics we have? I think it's kind of a sign of the times. I think the good news is we're talking about it. That's the first step.
And I think, as you pointed out, it's not a new problem in healthcare. I mean, this has been an issue in healthcare since clinical trials were invented. It's in some ways more amplified now because of the implications of generative AI.
Yeah,
Great.
I'll just lean into a couple areas where we're seeing innovation right now. Again, we're first check-in, so very, very early stage. But one is looking at co-pilots or diagnoses as options instead of here's what you should do. And it actually puts power back into the patient's hands too, to say, okay, so one of our companies is doing that in the dental space. So the dentist can say, here are some options for you to pursue. Here are the things you need to think about if you go down this one. If you take this option, this is going to be cheaper for you now. There's a high probability that you could end up with this later. However, I'm not going to tell you which way to go. So then you're starting to train based on maybe a wider variety of population, but to your point, if it's all in the Midwest, it might be a little bit more narrow. But if that's spread across multiple geographies and lots of people are seeing that same data spread across all the geographies, it starts to even out a little bit. The other thing is On the viewing of the data, one of the companies that we're working with right now is creating kind of a graphical interface for black box AI. So if you created a model one way, it's one thing to look at lines and lines of code of that model. It's another thing to look at a graphical interface and say, hey, we're seeing that this is spitting out the same answer over and over again. What if we were to come in here and look at what that is and change that a little bit? And what can we do? What can we add to that particular, point of decision making and the data therein? So I think there's a lot of, again, very early stage, but there's a lot coming. Oh, and then final, I really, really love to make sure the founders I'm looking at are as broad of a pool as possible. So the founder, herself, himself, themselves, whatever it happens to be, the founder is coming at it from their perspective, and that's a pretty broad base too. So there's some things coming, but if you look at the old pool of data, it's still pretty, monolithic, monochromatic. But I think more and more is coming.
I agree with all of my panelists, and maybe I'll put maybe a positive spin on where I think generative AI can help address some of the inequity and maybe leveling some of the playing fields, right? Obviously, all these concerns were still really early in the innings of really understanding the biases that are built into our AI models. But if we put aside the clinical use cases and the administrative use cases, right, I think we're seeing a lot of the potentials of generative AI, as Jill mentioned, like to significantly reduce the complexity that's built into our healthcare system on the administrative side, clinical documentation. I think where one of the challenges of the inequity that existed in our healthcare ecosystem, it's not just a ratio, there's a lot of biases within it, but think about rural versus urban, as well as even senior population versus the younger population, right? So there's a built-in inequity across all aspects of life. And over the last 10 years, and just talking about major trends, right, we have more and more facilities, provider, hospital, primary care shutting down in rural America, also shutting down in inner city America, shutting down in all aspects, fewer and fewer people going into geriatric care despite we have an aging population, right? So I think the reason behind some of that and going to the business side is that the business of doing healthcare is becoming harder and harder because of the administrative cost becomes higher and higher, right? So perhaps there's a way, like one of the ways for us to be able to afford building more affordable clinics to address the population in rural America is by incorporating many of these tools that we're now coming to an age. And so maybe as an investor, technology aside, of course, we're constantly looking at the maybe hundreds of generative AI companies coming to our desk on a weekly basis, but we're particularly really excited about new care delivery model that's, I know it sounds very cliche, but really built on the AI native tech stack, right? Because then they can go into more geographies, serve different populations in a affordable, in a business, in a cost structure that can really benefit and address the inequity that currently exists in all aspects of our healthcare ecosystem.
Thank you all. I want to try to hit one or two major themes before we open it up to the audience for some questions as well. So from a health system perspective, we see this very noticeable and somewhat concerning trend of migration of care out of the hospital into ambulatory care centers, out of ambulatory care centers and into doctors' offices, out of the doctor's office and into the home. And we see some degree of technological facilitation there, some degree of patient demand, payer push in that direction. And from the health system perspective, it's a concerning trend because we have these big expensive assets with a lot of sunk cost in the form of the hospital. So my question for you is, how do you see innovation further fueling that decentralization of care delivery? Do you think that we're witnessing the actualization of disruptive innovation in healthcare? And what do you think that means for both new entrants as well as existing systems?
I'll
Go
take
ahead,
the
Curdy.
bullet first.
Yeah,
Okay. I do think, as in any startup organization, any innovative organization, you really do need to listen to the customer. So I get it. We have a lot of costs in these systems, but I would encourage every single system out there to be thinking about, what do people really want? What are they asking for? What do they need? What kind of price points can they afford? What type of service are they looking for? And this, this is strategy 101. What assets do we have? Can we leverage some of those? Do we need to repurpose some of those? Do we need to think about what type of training we need for the future? It really is a point in time where, and it's not just today. As I said, I sat on a hospital board for 9 years. Some of those same conversations, different tech, but taking place over many, many years. We really need to stop having the tail wag the dog and really think about, what is the world in need of, and how can we leverage our great assets to provide them what they need.
If I may comment on this, I know, Max, you and I were Clay Christensen's student, and of course, the late Clay Christensen, who coined the term disruptive innovation. I'm one of his disciples, so I will always advocate disruptive innovation. And we have seen the decentralization of healthcare, right? And Clay, not going into the whole his theory, but there's a centralization, decentralization of in different phases of the innovation. I think healthcare is primed for decentralization, and technology will facilitate that, right? I mean, I think, take one example, right? Like hospital at home, right? Like actually when Bruce Lee developed that in the 90s in Johns Hopkins, right? And adopted around the world, it's a proven model. Many of the hospital care can be moved from inpatient facility to outpatient and then to the home, right? So that's the natural course of the innovation. I don't think that is it today. Well, over the last maybe 25 years, it's not a technology solve. It's really, at the end of the day, it's a business. And I think it's really to, Max, the point, I think the other way, healthcare doesn't necessarily behave like any other market, right? I think one of the things I have always kept in mind, and even when I wrote an article about after Clay's funeral, to talk about his theory of decentralization, disruptive innovation. But one of the challenges of adopting some sort of these disruptive innovation model is actually and I put it in the category of employment, right? Because we cannot solve the issue in a silo just to solve healthcare innovation. It's like when we look around the country, oftentimes healthcare company, be it the providers or the insurance companies, are the largest employers in your local market. And when our country's GDP, 18% of the GDP is tied to the healthcare industry, there's a lot of jobs at stake, right? So even if it makes sense from a free market innovation standpoint, but unless we address the job market issue, I don't think we'll ever truly see the disruptive innovation, because it will become way too disruptive in the market.
The other kind of aspect, of the medical devices, of the 900 medical devices that I talked about that are AI enabled, most of the way that AI is used in those is it kind of empowers and enhances the data quality, right? So it's actually super practical. Right now, it's not foundation models, LLMs are not standard in medical device industry. It tends to be a few years behind. But in fact, those devices look at performance. So in an EEG, you can now have much richer data coming out of a single electrode than you have many, right? So that's one example. Same is true in cardiovascular and in the radiology. I can give you the hyperfine example, which is if you're a patient in a spoke hospital, so in a hub and spoke model, you're a patient and you have a stroke and you're in Boston, you'll go to Mass General and you'll get an MRI as part of your stroke workup, and that will tell you whether or not you have an actionable stroke, and then you'll quickly be kind of triaged into thrombectomy, et cetera, and all of that. If you have a stroke in rural Mississippi right now, you'll go to a spoke hospital, they'll have a CT most likely, not a comprehensive stroke center. Depending on the type of stroke, that CT or CTA will come up negative, and then you get into a wait situation. So 80% of strokes aren't actually acted upon still today. So 800,000 strokes, 80% of those aren't acted upon. And if you could then insert in the hyperfine example an MRI there, you'd be able to triage that patient much, much sooner, instead of getting into an ED boarding situation, right, where now the likelihood of a patient event increases by 5% every hour, right? So now you're accessing, you've created technology, AI-enabled technology, you have a richer data set, you can actually get an image that's clinically meaningful, and then you can triage that patient and say, actually, no, we need to send you to an urban center now. And you can make that transport decision. Instead of saying, like, this is expensive to make that transport decision, I don't know if I can help this patient, so let's just have him wait, right? So it's happening. It's happening now, and I think it's actually really exciting.
I think there's an economics problem hidden in your question. I won't try to focus on that, but the thing that we're actually seeing in the industry in general is if highly profitable patients shift out of the hospital, and the hospital only has to deal with super complicated patients that they're always fighting with the insurance companies over, their lower margin patients, hospitals are already dangerously close to, like, the solvency line. And that there's some very significant percentage of hospitals that are below that line today. And so if it gets worse, it's going to continue to get worse, and then you don't have these centers to actually go to over time, right? So I think it is complicated. I do think that AI kind of propels decentralization, but what we're seeing is gigantic institutions that are recognizable in terms of their brand. They're creating AI models based on the data that they have and the outcomes that they've basically produced. So many years ago, I was working with the University of Pittsburgh Medical Center, and they said we've got 4 petabytes of information that go back to like before the 1900s. So we got the paper things that have actually been scanned. Now we've got modern images, la, 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 la. And they were talking about this before large language models, but they were basically saying, wouldn't it be great if we could actually create a system, a decision support system that we put out there on the open web, and then you've got some doctor that's sitting in some town in Idaho dealing with some patient that's a certain demographic, and they don't really have to do anything. Basically, the longitudinal record goes in as a natural processing mechanism, and then what comes out is everything that we've learned about patients that are actually just like this. And that turned into a use case called Patients Like Me or Patients Like Mine. And now Epic's even going further on that because they've got Cosmos. So there's 250 million lives or something like that, de-identified longitudinal records inside of Cosmos. And now what they're doing, they've got this thing called Best Care, and they're working with Microsoft on this in terms of the large language model side of it. But basically what they're trying to do is identify the best pathways for patients that have a certain set of comorbidities at a certain age, et cetera, and look at, like, if you were to put somebody on a certain drug or give them a certain procedure or whatever, they basically can graph it out now in terms of, like, how did that care pathway actually work out? What was the actual outcome? Now, the trick is you got to get your patient matched to the patient that you can actually do that analytics on. And now, if Cosmos is available to some town someplace out there, the person that could get really, really ill and end up in an acute care setting can possibly be kept out of the acute care setting because the intervention actually came faster, right? I think that's absolutely happening. And then on the med tech side, I remember a company, you probably know this company, like Butterfly or something. It was like an ultrasound.
Butterfly. Yeah.
I remember seeing that for the very, very first time, and they were talking about being in the field with the device, and they were talking about someplace in Africa or something. They're like, there's no way to even get an ultrasound machine there, but they scan it and it goes up into the cloud. So I think fundamentally what's happened is
He's got one right there.
Yeah. Oh, awesome. Yeah, there you go. So I think what's happened is AI, large language models today has democratized AI. so that English majors can write prompts and produce some really, really good results. And that's the democratization of AI. And then the cloud has access to democratization of the access of AI on the endpoint. And I think that's what's causing this kind of surge out, from the big hospitals.
Yeah, and I think that's exactly one of the things that presents such an enormous challenge for existing, what I'll call incumbent healthcare systems, again, to use Clay's language, and simultaneously opportunities for patients writ large across this country and internationally. Well, thank you all very much for all your comments. I think we'll open it up to the audience for any questions. If there's thoughts, there's a lot of areas we didn't get to probe into. We didn't even touch regulatory. Lee?
No one's ever accused me of not speaking loudly enough. I wanted to come back to the issue that you brought up and this sort of didn't really stay on about hyper-personalization in the models versus, is that discriminatory, is that bias? And I think I'd love your thoughts on the idea of what are we actually trying to build? Are we trying to build a single large language model that gives the best answer across a broad population, the average answer? Or is what we really want hyper-personalized outcomes so that as a 48-year-old white man living in the Midwest, you get one recommendation, but as a 13-year-old Black woman living in the South, you get a different answer. And whether that's one model tuned in different populations or whether that's different versions, instances of those models. The other piece of this question is as more and more health systems are taking instances and bringing them inside their own firewall so they can train them on their own data, how do you figure out how to extract some of those learnings in the form of metadata without extracting data so that the parent model can benefit, but that the intellectual property of the health system is preserved?
Yeah, so thanks, Lee, for the question. I hate it when people come up to me and say, what's going to happen in 5 years? Because they sit there and I'm like, I make it all up, and it's, no one ever comes back to me and tells me I'm wrong. But
we'll see you in 5 years.
Yes, exactly. I'm convinced of this. This is actually what I want. I want my own large language model. I want mine. I want the Joe Petro large language model, and I want it to cover everything from finances to when I get in a troubled situation with my wife, how to talk to her. How do I talk to my kids? My son has dyslexia. I've learned a lot about dyslexia over the years, and my health, because I'm personally sick and tired of talking to my personal physician, who I like a lot, but we're all caught in the same healthcare system. I'm sick and tired of repeating myself. I'm sick and tired of bringing him up to speed. I'm sick and tired of reminding him I'm on a blood thinner, and do you really want to give me that drug? Being a physician is a complicated thing. But if I had my own model that knew everything about me, you ground it in yourself, right? So you just load all of your stuff, all your longitudinal, and then I carry it around on my phone, and maybe it's in the cloud. That's an amazing destination. Like, that's where I want to go. I think the problem today, in terms of where we're at, is that this whole notion of like a general reasoner, which means a really smart kind of general intelligence. It just happened, right? We're only about 18 months old. The thing is, we've been doing AI now for 20 years. And it's like, I know a lot about Mass General, because they're one of our clients. One of the things Keith Dreyer, the kind of the radiology czar there, he basically shows this diagram, and it's these little squares, and each one of the squares is like a diagnostic condition that a radiologist needs to read for. And he zooms into it, and you're like, oh, that's manageable. And then he zooms out. He's like, these are all of them. And it's the little squares that have white turn into black dots practically. And it's unmanageable to create a model for every single one of them. That's where we are today. Now there's this ideology. This is where it intersects and gets complicated. I think there are ideologues in the research and scientific and even academic community that are saying there's going to be 4 or 5 God models. They call them frontier models. They don't like the God model thing because it sets people off. God models, 4 or 5 of them owned by like the hyperscalers, the biggest companies in the world that know everything about everything. The practical side of me, knowing what I know about what happens in the models and also practical engineering, I think it's insane to think that, right? I think we have to, maybe it'll happen someday, 10 years from now, but we have to have a progression that builds on value and capability. And I think it starts to answer some of your questions. But ultimately, I'm convinced we're going to have our own models that do a lot for us as individuals.
Great talk, by the way. So I've heard about Gen AI and its impact, and there's a lot of work that has to be figured out, and biases and so on. How does that tie into, and where's the future for predictive AI when it comes to healthcare? And which one is going to have a greater impact for society?
So if you take the radiology example, what's really, I mean, I think what's most interesting right now is empowering the radiologist. So, basically you have 1,900 posts on the ACR website right now for radiologist posts that are open, right? Like Joe talked about. I mean, clinicians and radiologists are burnt out, and all of the metrics are kind of going in the wrong direction. Collecting data, right, for them, especially the non-interpretive data, all of the administrative tasks, right, and giving them insights kind of along the journey. Now all of a sudden gives you a more empowered workforce, radiological workforce, right, and it moves us in the right direction. So there are models that allow us to do that, right, and I think again radiology is a really kind of first example because the language is the same. It's the language of images. It's the language of EHRs. It's the language of collating, collecting data, ingesting data, and then outputting something that's a lot more insightful about the patient than any one person can do. Because right now in our health system, it's just a bunch of disparate data sets. We from getting to God models to kind of just getting the data in front of you, right? It's still a long journey in healthcare. I think healthcare is still way, way, way behind, right? Where Microsoft and other companies are, and it'll be that way for a while. And the first thing is getting the data, presenting it to the clinician, and then presenting it to the patient. So everything we know about you, instead of these one-off kind of data points about, okay, well, I saw you on this date, and this is kind of the kind of what we saw there, the whole history of that patient, and to me that's most critical.
And we're really early days, but I'm seeing a lot in the nutrition area too. So you know your DNA, right? You know what you're putting into your body, and predicting where you're going to end up with sugar, with any other substance. It's rudimentary right now, but literally the possibilities are huge. So you can get an answer for if you keep down this path, or you've got a void of this type of nutrition in your body. You need to put that in now if you're going to be healthy.
I think we have time for one more question.
Yeah, Joe, thank you. Great talk. I had a two-part question. So once we see a trend in some of these models that are, some companies open source their models versus some like OpenAI, I think is closed source. Meta open sourced their Llama models. What are the pros and cons? And like who certifies these models? Are they in terms of accuracy? And also, like if we upload our personalized model to the cloud, how can we prevent, or is there a risk of cloud companies monetizing on our personalized models?
No risk.
Yeah, you had to ask that. Yeah, so that open source versus commercial software is obviously a big topic that lots of folks discuss. I think in the AI world, I think it's well understood in software. In the AI world, I think what you're seeing happening is open source is almost like an open source version of a model. It's almost like a private preview that everyone can use and play with for quote unquote research purposes. You have to look at like the terms and conditions of the model itself, and then it ends up becoming commercializable and licensable on the other side of that, after you've kind of like subjected it to the scrutiny of the wild. And lots of companies do that. Microsoft today is doing that with their Phi models. So Phi is like, think of it as like a multi-billion parameter transformer that in certain narrow domains has similar capabilities to GPT-4, but it's super fast, like low latency, and super low cost because you're not dragging a trillion parameters along for for the ride. In terms of the other thing, in terms of who's like regulating this thing, who's actually certifying that the model does what it says it does. Right now, we're all in the hands of some of the biggest tech companies in the world, and I think this is where it gets into this kind of somewhat academic discussion around like who's responsible for what, who's accountable. I think it comes down to trust. And when you pick a model, you have to know enough about what the company is actually saying about what the model does, what they're actually signing up for. Right now, nobody's signing up for anything. Nobody's signing up for quality, right? And this gets particularly thorny when you get into the diagnostic space and so forth. That's why when you pick a specialty company that's focused on like imaging diagnostics based on AI, you kind of know what you're getting, because they're scared to death that someone's going to sue the hell out of them because they misrepresented the model or said it does something that it actually doesn't, and it's narrowly defined. And I think that like Microsoft does a lot of work in this area, and I think they are the leaders in terms of the way they actually think about it. I go through hell when I want to release a product. There's something called the Deployment Safety Board. It's called the DSB. It's part of the Office of Responsible AI. I call them the Office of No. What happens is I make an update to the model. I can change the prompt. I can change 3 words in the prompt. I call them up and say, does this have to be reviewed again? The answer is always yes. And then I say, I want to get it out there. They put what's called a red team on it. And the red team are human beings that beat the hell out of the model and try to make it do something really bad, right? They intentionally try to make the model go off the rails. And I think there's going to be more and more published about this over time. It's going to be less of a secret. But if you read, Microsoft has got a really good paper on this. It's called the AI Transparency Report or something to that effect. You should take a look at that because it talks in detail about all this stuff. Just be super critical of it. Like when you're reading it, just like think through how are they measuring this? What's the tool behind it? Because you got to kind of connect those dots. But I think we're in the super early days right now.
So I'd just like to take a moment to thank our panel, Ian, Curdy, Joe, and Tom, and please join me in providing a round of applause.